I would like to thank the opportunity to speak and thank you to the Wilson Disease Association for this opportunity. Thank you guys for coming to this conference, and also thank you to Dr. Shulsky for always his mentorship and guidance. So I would like to kind of take a whirlwind tour of how we look at Wilson's disease from a hepatology perspective. I think it's always good to kind of step back and think a little bit about the big picture. So how does copper metabolism work, right? So we take in copper anywhere from 2 to 5 milligrams in our diet every day. A large portion of it is absorbed in the small intestine and then is basically taken to the liver. It's important to know that the liver plays a really key role in the distribution and processing of the copper. As you can see here, the dietary copper is then absorbed through the intestine and goes to the liver. The liver then kind of packages and transports it in various manners. As Dr. Alla has gone through, it packages into ceruloplasmin and transports it. There's the non-ceruloplasmin copper that can be used for extrahepatic copper utilization. There's also the urine copper is excreted, and we ask you to collect. And also there's biliary copper excretion. So you see the liver is playing a very central role in the regulation and processing of the copper. So like to what Dr. Alla has said, why does Wilson disease happen? And it really happens because there's a mutation in the ATP7B gene, and it's the underlying basis for the disease. The protein is expressed along the liver cells and really helps transport the copper out of the cells. And when there's a mutation in this gene, it can lead to protein dysfunction and then to copper overload. So why does that matter? Why do we care that there is this copper accumulation that occurs in the cell? And when it can't excrete, it accumulates, and then the copper can cause injury in the cell itself. So by this chemical reaction you see on the side here, it induces a generation of reactive oxygen species called free radicals. And these free radicals can cause damage on the cellular level. So it can cause cell membrane damage, mitochondrial damage, DNA damage. It can inhibit protein activity and it can induce cell death. So it's important to see from a kind of a cellular level what's happening kind of on a big picture level, right? So this oxidative damage that's produced by the excess copper, which can lead to inflammation, activates these special cells within the liver called stellate cells to induce scarring, which a medical term we use is fibrosis. And the degree of liver disease really, when a patient presents to us, really kind of varies. It depends on the environmental exposures. The patient has fat in their liver, alcohol use, other potential liver disease, environmental factors. And what this diagram kind of takes a look at really is kind of showing you the stages of scarring. So you see on the side here where this F0 standing for fibrosis 0 is that this is the liver that's without scarring, so it's fully without fibrosis. And as time moves on, and there's more injury and damage, the fibrosis and scarring continues to stage 4, which is where you have what we call cirrhosis, and that's when the liver is fully scarred. So, I think it's always surprising when I was, shadowing Dr. Shulsky in his clinic when I was a fellow, what really kind of caught me and really interested me for this to be a lifelong research love is really how varying the presentations could be. And it really could be patients that are coming in that are completely asymptomatic. They're coming because they have a family member who was diagnosed with Wilson's disease, or their primary care doctor doing the routine blood work and noticing that their liver numbers were off. We see patients who have compensated cirrhosis, which basically, again, means the liver is fully scarred, but the liver is able to do the function that it needs to do to kind of maintain the body's function. And then there's also decompensated cirrhosis, which is the liver is fully scarred, but the liver really can't do the function it needs to do. And that can be manifested by any one of these 4 symptoms: jaundice, which is the yellowing of the eyes and skin, ascites, where you develop fluid in the stomach or in the abdominal area. Encephalopathy is when the liver really can't remove all the toxins, ammonia in the blood, and the patient can present as confused. Or patients can bleed from these varicose veins that develop in the esophagus, and we call that a variceal bleed. And we've also seen cases of acute liver failure for Wilson's disease as well. So we looked at the big level, but what happens on a microscopic level? And I think to Dr. Allen's point as well, this is a beautiful presentation of what, copper staining in a liver biopsy looks like. But we have been fooled, right? It can really look like fat in the liver, which we call as metabolic dysfunction-associated steatohepatitis, which is a shorter name will be MASH. It could look like cholestatic liver diseases. It could look like autoimmune hepatitis. The biopsy is helpful for us. Sometimes diagnoses are not very clear, and so we actually get a liver biopsy to get a look at dry copper weight. And it's also helpful to determine fibrosis staging. We also can't ignore that just because a patient has Wilson's disease doesn't mean that they can't have other potential liver injury. So fat in the liver can make the liver injury worse, and alcohol use as well. So we don't always go parading around and poking needles into the liver to understand the fibrosis staging of a patient. Other tools that we use include a fiber scan, which is pictured here, and is a probe that looks at the stiffness of the liver. Other things we could do is look at the blood work and use calculations that we looked here, which is the FIB4 and the APRI, which can allow us to understand, the trajectory of a patient, how much scarring is accumulating over time. None of these tests are perfect, but it does help give us some picture of what's going on in the liver without doing a biopsy. So taking a step back and thinking about, so how do we manage these patients when they come through our door? How do we think about, making them the healthy person they once were? And it's really trying first to obtain a copper balance. And then the next step would be trying to reduce the fibrosis and inflammation that occurs in the liver, and if present, management of the complications of cirrhosis. Cirrhosis management includes really monitoring for liver cancer every 6 months. May that be ultrasound, CT scan, or MRI. We screen for those varicose veins in the esophagus with endoscopies. We manage fluid status, so the patient presents with a lot of swelling in the legs or in the stomach. We give medications to help with that. And then also management of encephalopathy, which is meaning giving medications to help kind of clear those toxins and ammonia by promoting bowel movements in the patient. And then liver transplant is something we think about as well. I'll go into a little bit more detail about that in a later slide. So how do we achieve this copper balance? And I love this diagram, which Dr. Shulsky kindly shared with me, because you can kind of see where we target our treatments. We think about we tell you, have a low copper diet. We give zinc to help prevent intestinal copper absorption. Triantine and penicillamine helps promote the excretion of the non-ceruloplasmin copper into the urine. And as a transplant hepatologist, I can never forget about thinking about transplant for my patients. And so that comes up a lot. Our patients ask, well, how do you know that I'm being treated appropriate? How do you know you're not over-treating me or under-treating me? And so I took this from the American Association of Liver Disease guidelines that was published in 2023, which Dr. Shulsky is one of the authors therein. But we look at non-ceruloplasmin copper and 24-hour urine copper excretion to guide therapy. And this is the brief table I pulled just so that you can kind of see there's kind of the ranges we look at when we look at our patients who are coming through our clinic on therapy. The next few slides are a few studies I'm briefly touching on about the newer things that are coming down the pipeline, but I think a lot of my colleagues in the later sessions will be going into a little bit more detail about those. So the Chelate trial was a big trial. It allowed us to see that triantine was a non-inferior to penicillamine in patients with stable Wilson disease, a very much needed study. Also, it was very interesting. This was published in our hepatology journal, which looked at potentially another mechanism of trientine besides the urinary copper excretion, showing that trientine actually inhibits intestinal uptake of copper, whereas penicillamine did not. And also very exciting is this animal model study that looked at methane oxidizing bacteria called methanobactin that restored biliary copper excretion in Wilson's disease rats. So more exciting things to come. And again, as a transplant hepatologist, I always ask myself, when do we transplant? And I think this question comes up when we see a patient with decompensated cirrhosis, like those symptoms we talked about, a patient who has full scarring of their liver, they have either ascites, jaundice, encephalopathy, or have had a varicose bleed. We obviously very much think about it in acute liver failure as well. But sometimes, the patient does not follow the textbooks, and it's very hard to kind of know where the trajectory of the patient is coming into the clinic or the hospital, where they're heading, if they're going to really do well with the transplant, or will they can do kind of skate by with chelation therapy. And so we use these prognostic scores, the NASER score, which is shown here. These are all obtained from your blood work, and we kind of calculate to kind of see where the trajectory of our patients are going, whether we need to really move forward towards transplant. Another score is the New Wilson Index, again, also blood work that we obtain from our patient to do the scoring system, and of course the MELD score as well. So I think in summary, ATP is a protein that helps transport copper out of cells. Wilson disease is caused by a mutation in the ATP7B gene that leads to copper accumulation in the liver and later in other sites, leading to injury. Remember, there can be different hepatic presentations of Wilson's disease, and management treatment is aimed at obtaining copper balance and management of cirrhosis and decompensated disease if present. Thank you.